Hello and welcome back to Brain Pods. I think we are now on what this is Coma and Consciousness, so this is number 3. So I have with me, I'm very excited to have Dr. Jamie Starks with me. You remember her from HHD5. She is doing Coma and Consciousness today. We'll later do cognitive disorders, movement disorders, dementia specialist. We are here at her fabulous office at the VA. As thank you for inviting me. So this is a little bit of a take off of the Coma and Consciousness talk you gave at HHD 5, but we're going to expand it. We're going to talk about management. We got some fun neurosurgical videos. I have my own little ruminations about consciousness because this is one of those cool things in neurology where if you just stop to think about it for a little bit, just like, why am I aware of the world around me, and how does that happen?
Yeah, it's one of those fun intersections with like philosophy and the humanities and
absolutely
all that good stuff.
All right, so we're just going to go ahead and dive right into it. And Bran of Tarth is here with us today. Dr. Starks was a little disappointed that we did not bring one of the Starks along. Do you have a favorite? Arya, maybe?
Probably Arya.
Arya.
It's hard not to go with Arya.
I am still upset.
Spoilers.
No spoilers.
Okay.
No spoilers. Good. Touche. I'm still upset that season 7 only had 7 episodes, though. I'm really angry about that still. It's been a year almost. All right. There we go. Here we go. Okay. Go ahead, Dr. Starks.
All right. So consciousness. Let's see. How do we do this?
So there we go.
So as we did a year ago, we are going to be trying to define consciousness and differentiate it from arousal and or differentiating arousal from awareness. I want you all to be able to identify the basic neuroanatomical structures that underlie this thing we call consciousness. And then clinically, you should learn to differentiate a structural versus a metabolic coma based on clinical features, because it really informs the way that you might diagnose the underlying cause as well as the management. And then lastly, we want you to all to be able to identify clinical features and causes of encephalopathy or delirium.
And we'll also go a little bit over management of whether or not these are intracranial hemorrhages, as well as a few classic metabolic syndromes.
So what is consciousness? This is a topic that's been debated in different fields for many years. The medical field has sort of settled on a definition of consciousness as a state of full awareness of both one's self as well as one's relationship to the environment. And built into consciousness are really 2 basic components. One is awareness, which is being aware of one's environment and being able to react to it. But in order to be aware, you also have to be awake. You have to be alert and awake, which is something that we refer to as arousal. So it's somewhat intuitive that you need to be awake in order to be aware of your surroundings, but you can be awake without being aware of your surroundings. So while awareness requires wakefulness, wakefulness can be present without awareness.
And actually, I have a little, in my musings a couple slides from now, I have a couple examples of studies that have looked at it.
So a brief review of the anatomy of consciousness. It's useful to think about this as sort of a light bulb, light switch analogy, where the light switch to consciousness is the reticular activating system, which lives in the brainstem. That's sort of the switch on and off if in order to be aware of your surroundings via the cerebral hemispheres, you need the light switch to be on. The cerebral hemispheres are kind of like the light bulbs that illuminate your awareness and your world around you, and they can be anywhere from fully on, fully bright, fully aware, to dim and only partially aware. So while the reticular activating system is more of an all or nothing structure, the cerebral hemispheres are have many different gradations between fully aware and not fully aware. And then the thalami, as always, are kind of the conduit in between. So they are the switchboard between the reticular activating system and the cerebral hemispheres. And this is just another depiction of that system. So you can see the projections from the reticular activating system up to the cerebrum are really widespread. And so in order to have impaired consciousness, you either need a lesion in the reticular activating system,
Mm-hmm.
or in both thalami, or in the entire cerebral hemispheres, because it's such the projections to the cerebral hemispheres are so diffuse.
That's really the anatomy that's helpful here, right? I mean, if you're thinking about, I mean, you can knock out a huge amount of one of your hemispheres and still be perfectly conscious.
Yeah.
However,
because you've got all this other hemisphere still there.
right. And however, if you have a big lesion in one of your hemispheres, but it's causing a herniation syndrome that's now starting to compress the reticular activating system,
The light switch goes off.
yeah, bingo. All right, very cool. So that is the basics in terms of when we're in a ICU, for example, evaluating somebody with consciousness. Let's one of the goals I had with Neuropods is to give high yield step 2 clinically relevant material. The next 5 minutes probably does not fit that goal, but only because I think this is one of those things that is just so inherently fascinating to being alive. I mean, a lot, when you can't make it into and through medical school, I think, without being just fascinated by human physiology, right? Mm-hmm. And neurology is just filled with, how do our eyes move? What is sleep? What are dreams? And various aspects of cognition, language, music appreciation. This is just a chance for you to opine, since whether or not you want to or not, you are going to be thought of as a learned individual about the human nervous system as you are training to be physicians. So if that does not interest you, jump right past for the next 5 minutes. I will not be offended. But this is just some thoughts I've put together on consciousness as I've spoken about this before. All right, so pondering consciousness in 8 slides. So when neuroscientists have investigated consciousness, unfortunately, this is one of those things where you can't understand it until you reduce it down to smaller concepts. And one thought to immediately recognize is that with functional neuroimaging, you can deliver, you can measure the brain with a PET scan or function. But let's just say PET scan, EEG. You can deliver a stimuli that's visual, auditory, and you will see the brain respond to that. Mm-hmm. If it's so fast, you won't even see the brain respond to it. But if it's fast enough, let's say 50 milliseconds or so, the brain will respond to it, but we can't recall it. Some image flashed up, we wouldn't be able to describe it at all. However, inside your head, your brain perceived it to some degree. It seems to be that the critical threshold has to be a stimuli of about 100 milliseconds, which is interesting, right? I mean, it tells that it needs to kind of process around and bounce around to enough neurons to reach a threshold for you to be aware of something. And there's an example of that later. So this is my daughter, Lauren. She is now almost 11, so I need to get new pictures of her. But this picture just tells me of someone who's aware. I love this picture. But I think when we try to, again, we got to break down what we're talking about here. Distinguish consciousness from self-reflection, right? And the example I think of here is when I think of my daughter Lauren now skiing, who's gone from this adorable little toddler now to a very impressive downhill skier. And when you're skiing, you do not have time to reflect upon it, right? You're appreciating your environment, visual input, proprioception, motor, auditory information. But
you're not pondering the tree that you're hurdling.
You don't have time to ponder the tree.
Right.
Now you can reflect upon it later. It's like, wow, wasn't that really awesome and cool? So distinguish self-reflection is to be distinguished from consciousness. And most of what we do, so of the 200 different things that your nervous system is doing right now, from sitting in the chair, whether or not you're standing or listening or just keeping an idea of something is happening over here in this visual field, the vast majority of what your brain does is on the subconscious level. Right? You have an executive summary of only a couple of things, and what are those? How do those couple of things come to your attention, and how do you shift them? Is kind of what I'm going to be getting at.
Well, like for example, if I were to tell you to think about what it feels like sitting in this chair, and how do your legs feel, and how does your butt feel sitting in this chair?
Right.
You didn't notice it all, but maybe you're actually a little bit uncomfortable.
Right.
Now your brain now that I draw attention to it.
Right.
Your brain has been kind of ignoring that.
Right. And my left foot is starting to itch now just thinking about it.
Exactly.
Right.
Exactly.
Which is, as an aside, is a real problem in sleep, because with people have insomnia, nobody ever laid awake in a dark room and thought about how great their life was, and then all of a sudden you think about all of these aches and pains that you otherwise, doesn't bother you enough. All right, so let's distinguish consciousness from, this is a little bit of what Dr. Starks was talking about a moment. Distinguish consciousness from attention. And it's just worth, since we love thinking of our computers in terms of storage and bits, just recognize that each one of your optic nerve processes about 1 megabyte of information a second. And attention is a way to focus certain information that your brain is recognizing on a subconscious level for higher processing. And this attention this consciousness provides an executive summary of all data. And here are just 2 studies which I thought were really interesting. The Jiang study, which looked at attention without consciousness, and the Mack et al. Study looked at consciousness without attention. And the Jiang study this is really fascinating. So they used, based on what we were talking about before, faster than 100 millisecond stimuli, so they couldn't remember it. But they took heterosexual men and they flashed up a picture of a naked woman at faster than 50 milliseconds. Yes. And guess what? They couldn't recall why, but their brain moved up. And then they would show a naked man, and their eyes would like subconsciously divert away. And so they were able to attend to something without being conscious of it. Conversely, they would do a GIST study where they would show up a landscape for longer than 100 milliseconds, but I don't know what length of period of time, but not nearly enough time for them to kind of look around. And just by getting the blast of information for 200, 300 milliseconds, they could say, yeah, there was a mountain, and there was a bird, and there was a car, and there was even though no way they could kind of look at all of those different things. So these are the different kind of ideas: attention, gist. A lot of things are happening. So what is the main theory in terms of where consciousness comes from? And it's mainly based on work out of Wisconsin, Tononi and Sorelli's integrated.
I worked in that lab.
That's
undergrad.
I totally forgot about that.
Yeah.
Did you know?
As a Lilly undergrad trying to get into medical school.
Integrated information theory?
I mean, we were in like lab meetings together.
That was
they
not.
wouldn't know me, but
I did not mean that to happen for this brain pause. That was like Brienne running into an important character later. That was really great. Okay, so this is the integrated information theory, which is that, just to state the obvious, human experience consciousness is dependent upon just a massive amount of information. But it's not just information, it's also its integration. So remember, 100 billion neurons, 100 trillion synapses, and they need to resonate together. Not only the amount of information needs to be working, it's not just the amount of information, but it also needs to be integrated together in a way that makes sense. So, for example, your cerebellum has a tremendous amount of neurons in it, but it's not conscious because it doesn't integrate together in a way that forms consciousness. Seizures, slow wave sleep, you have a massive amount of brain activity that's working together, but we're not conscious of it. So it's more than just pure numbers and density of activity. It needs to be integrated in a way. And there's different numerical ways of looking at this. They call complexes thetas, but the two big keys is there needs to be a large amount of information. That information needs to be integrated, and we're not going to get into how that happens, but it does happen primarily through the thalamus kind of pulling all this together, and it is fascinating. These are just the terminologies that you might come into. This is just a complex versus a main complex. So a complex is a system of related brain circuits, say visual, say auditory, say proprioception, to form one facet of consciousness. And the main complex is the network of complexes that come together to create the whole conscious experience, and that this main complex is dynamic. So the way I visualize this is, as you're just sitting there watching your screen or contemplating the world, is that you have various complexes that are picking up different aspects that you're not attending to, and that your main complex is what you attend to, and it can shift around. It's just like it's at any moment you can go to, focus more attention on vision, focus more attention on what you're listening to, emotions, all of those sorts of things. And final thought here, what binds all that together? And it seems to be this very important rhythm called the gamma rhythm, which is really high frequency. We don't see it on EEG. It's 50 to 70 hertz frequency, but it's really important. It's this synchronous neural dynamics in the 30 to 70 hertz range. And so the way I think about it is as if you have a certain area of your, and I just think of vision, but if you have a certain area of your visual field that you want to attend to, all of a sudden it starts syncing in that gamma frequency range with the rest of the brain. So it's operating on a high gamma frequency, as is other parts of your brain that operate on a high gamma frequency, but once they sync and they lock into each other, then you're all of a sudden attending to them. That's the way I visualize it. I don't know how well I explained that or not. But needless to say, this high frequency gamma rhythm is really important to your life. There's good reason to believe that it goes awry in certain brain conditions. Autism is one obvious one. And so if your gamma rhythm doesn't sync properly, you don't get like basics of consciousness and human interaction. All right. So how did I do, since former esteemed colleague from Tononi's lab in Wisconsin? We did okay?
We did okay.
All right.
We did all right.
All right, so now back to the real world of thinking about consciousness as a physician. So,
right. So thinking clinically, I'm often kind of simplifying things in my mind beyond maybe even what's really happening with gamma rhythms and all that.
Yeah.
So I break it down into these simplified thought processes. So again, thinking of consciousness, dividing it into wakefulness and arousal versus awareness of one's environment. Again, awareness really lives in the cerebral hemispheres.
Mm-hmm.
It's not as much of an all or nothing game. There's so much territory there that in order to completely darken the room, you have to have the light bulbs totally out. And the reticular activating system being really important for wakefulness and arousal. So you need, again, the reticular activating system has to be intact in order to have your cerebral hemispheres working and aware. But you can have your cerebral hemispheres working, you can have your reticular activating system
Mm-hmm.
working without the cerebral hemispheres working.
Absolutely, and a vegetative, which is often described as a vegetative state.
Yep.
Yep.
So let's move on to how this actually happens. So again, if in order to get impaired consciousness, you either need your entire cerebral hemispheres bilaterally out, both thalami, or the reticular activating system in the brainstem.
And a variety of different pathology can cause all of those things.
Exactly. So, another way to think about the different causes of impaired consciousness is dividing them into structural versus metabolic causes. The reason that this is clinically helpful is that it helps inform how we diagnostically approach what's causing this, and also how we might manage it. So when I walk into a coma exam, one of the things I'm really looking for is there any kind of asymmetry on this on this exam? Because if there's asymmetry, it tells me that there's probably something focal going on, a focal lesion that we can usually diagnose with either an MRI or CT or an EEG. If everything is completely symmetrical, it's more likely to be a diffuse process, so diffuse cerebral dysfunction, which is actually the more common cause of coma. So different structural causes of impaired consciousness, we can kind of further break that down into categories. Those that cause increased intracranial pressure, which we'll talk about in a little more detail in a moment, which leads to decreased cerebral perfusion. And that structurally can be caused by really big bad things. So a small hemorrhage or a small brain tumor, a small stroke, it's very rare to get impaired consciousness. But if you've got a very large hemorrhage that is expanded rapidly, or a very large ischemic stroke that has caused a lot of edema, it can be severe enough to decrease perfusion to the entire brain or the entire cerebral hemispheres because of that increase in intracranial pressure. Seizures really only cause impaired consciousness when the entire hemispheres are involved. This is why a focal seizure doesn't result in impaired awareness or consciousness, but status epilepticus, which is involving the entire hemispheres at once, causes you to lose consciousness. And then anything compressing the brainstem, which knocks out the reticular activating system, can cause coma. So this can happen either from one of those things on the top of the slide, squishing the brainstem via herniation, or you can get a process that selectively knocks out the brainstem, like a basilar stroke or a hemorrhage in the pons.
Okay, so and here's a nice example of, here are two different individuals, both of whom you could get a call in the intensive care unit, patient unconscious, please help, right? So, and on the left here, this is a structural lesion. It looks like an infarct, but it's not this lesion itself which causing the loss of consciousness. It's the increased intracranial pressure, which you can see because of the herniation syndrome. It's being pushed laterally. Also, undoubtedly, there's going to be uncal transtentorial pushing downward herniation as well, affecting the reticular activating system.
So when we examine this patient,
this one right here,
we are definitely going to be seeing some asymmetry in their limbs. One of them is going to be weak, and one of them is going to be more reactive if we pinch it or things like that. And they're also likely to have symptoms of herniation if we check their pupils, for example.
And this is just a reminder. This is the right side of the brain. So based upon this, we would be looking for left-sided weakness. Conversely, we would not expect focal findings on the examination here for someone who has metabolic encephalopathy, and this is an example of hepatic encephalopathy due to the numerous when the liver isn't functioning properly, doesn't clear out all the false neurotransmitters, and so you end up with a cortex that's not working.
And I would add that for a metabolic encephalopathy like this, usually the MRI is not necessary, because we, at this point, hopefully have already gotten some labs and know this person is in liver failure, and that if we treat that underlying cause, the encephalopathy should resolve. But that coma exam really helps inform where we should be directing our efforts. Is this just hepatic encephalopathy, or has this person had a big stroke that we need to know about?
And just to emphasize what Dr. Stark said before, is the key feature is the asymmetry. That's why that is underlined and highlighted.
So going back to increased intracranial pressure, why does this actually lead to impaired consciousness? The pathophysiology really comes back to the fact that our skull is a fixed volume. Any change in one of the components within it must be compensated by reciprocal change in the volume of another component. So the way this usually happens is that, let's say you've got that big stroke that we were looking at. As there's increased swelling and the sort of the brain or pathology component is increasing, that's normally not there, it has to come from somewhere. So initially, it comes from the CSF volume. Our ventricles don't really need to be that big, so we've got a little bit of wiggle room there. But once the CSF volume has been depleted, then the vascular structures start to be compressed. And as the blood vessels are compressed, of course, that leads to less blood flow to the brain. And less cerebral perfusion pressure. So this ends up being a vicious cycle because, of course, the body's response to decreased blood flow to the brain is to say, well, let's get more to the brain. So the systemic blood pressure, the mean arterial pressure, increases in order to try to get more to the brain. But what ends up happening is that just leads to more blood volume, which we already know we don't have room for.
Right.
So it further increases the intracranial pressure,
Yep.
leading to even more decreased cerebral perfusion pressure. So it's just a vicious cycle. So the bottom line is when you've got this pathology that's creating new volume that normally isn't there, we need to do something to get rid of that so that the blood vessels and the brain itself don't become compromised.
Can you talk a little bit about brain volume and age and how that plays a role, with a very practical role when you're talking about this concern?
Yeah. So, for better or for worse, our all of our brains are going to shrink as we get older. I'm sorry to tell you, but it's natural. Of course, people with cognitive impairment or dementia, they have even more brain shrinkage as they get older. But in the situation of a big bad stroke like this, that shrinkage is actually to one's advantage. So the brain volume being decreased, usually that's replaced by increased CSF volume, right? There's just more space in between the gyri when we look at an old person's brain. So it means that there's more wiggle room when there's a big mass lesion. So if I were looking at this size stroke in somebody who's 90 years old, I am much less worried about it than in an individual who is 30 years old and for some reason has had this big stroke. They are going to herniate much, much, much more quickly. I've seen it happen within hours as opposed to an elderly person. It buys you time.
So young people diseases, you absolutely can get strokes from dissections, HSV encephalitis, trauma, intracerebral hemorrhage. It's a matter, even if they're looking pretty good, neurosurgery needs to be taught. In the intensive care unit, neurosurgery needs to talk about doing a hemicraniotomy, which we're going to get into in just a moment on what that looks like. Okay, so what happens when you fail to bring the intracranial pressure down in someone who has elevated intracranial pressure? Okay, so this is over here on the right. This is what a normal brain perfusion scan looks like. You see the red equals blood perfusion essentially. And this is someone who has normal blood perfusion. And someone who has increased intracranial pressure, you don't get the adequate perfusion, and so you end up with this massive infarction because you're not able to perfuse blood to the brain because there's just so much pressure up in the head.
You're essentially stroking out your entire brain.
Your entire brain. And that's what it looks like, tragically.
That's bad. So how do we know that increased intracranial pressure is present? If somebody's not yet in a coma, how can we try to detect this early before they get to that critical period? So there's a few kind of characteristic clinical signs. One is headache, and in particular, headaches that are worse with certain positions or activities. So if you think about increased intracranial pressure causing a headache because it's sort of, as there's increased pressure in the brain, it's causing expansion and pressure on the meninges, which is where headaches come from. It's stretching of the meninges.
Yep.
Anything that makes that pressure just a little bit worse is going to make your headache a little bit worse. So you can imagine if you're like doing a handstand versus sitting up in a chair, you're going to have more pressure as you're upside down. Similarly, when you're just laying down, and especially for a long period of time, gravity is not helpful in reducing your increase in intracranial pressure. Anything that increases intrathoracic pressure, like coughing or Valsalva, sneezing, can also cause transient worsening of the increased intracranial pressure. So those are kind of red flag symptoms of headaches that should make you think about this. Vomiting can also occur because of pressure on the vomiting centers in the brainstem. If you're seeing some of these red flag symptoms, you want to get out your ophthalmoscope and look in somebody's eye, because recall that the optic nerve is actually part of the central nervous system, and the sheath around the optic nerve is continuous with the subarachnoid space of the brain. So it serves as a little window into the brain. And you can see papilledema, which is pictured right here, and engorgement of blood vessels in somebody who's got increased intracranial pressure. You start becoming really worried when you start getting decreased alertness, because that is the first sign that your vascular structures are being compromised and your cerebral perfusion pressure is dropping. Signs of brain herniation or Cushing's triad mean you're really in the danger zone, because these occur really late. Cushing's triad occurs because, as we said, as the body's trying to compensate for the decreased perfusion pressure to the brain, it tries to get more blood to the brain by increasing blood pressure. So you get hypertension. That blood pressure increase is detected by your baroreceptors, which then in turn activates the parasympathetic, so you actually get a decreased heart rate. And the last part of the triad is irregular respirations, hyperventilation that occur because of the respiratory control centers in the brainstem starting to be compromised.
Cushing's triad, this has got to be a step 2 question.
For sure.
Yeah, this is step money right here.
So what do we do about this? There's conservative management, and then there's neurosurgical interventions, which are really the definitive way to solve this problem. Of course, it's good to avoid removing part of the skull or drilling into the skull and brain if you can, but often these more conservative measures are just kind of buying time. So one strategy is to try to pull unnecessary fluid out of the brain, especially if there's a lot of edema in the brain that doesn't need to be there. And we can do this with osmotic therapy. So remember back to how osmosis works. When you've got a lot of edema in the brain, you can take advantage of putting a hypertonic saline in the blood to try to pull the water out osmotically, because the two compartments are always going to try to equalize, right? Mannitol is another hyper osmotic solution that we can just put in the vein or into an art line to try to draw out that fluid. Hyperventilation can very transiently reduce cerebral blood flow, because cerebral blood flow is largely determined by CO2 in the brain. That's how it kind of detects how much blood is coming and going. So if you're breathing off a lot of CO2, your brain interprets that as there's blood is sort of leaving the brain. So it decides to vasoconstrict to try to keep what it's got in the brain, and that ultimately reduces cerebral blood flow and that vascular blood volume. As you can imagine, that's not a terribly big effect, and it's really a transient, just a temporizing measure that you can that you can take especially if someone's on a ventilator. You just turn up their vent frequency while you're on the phone with neurosurgery, basically.
Yep.
Ultimately, the definitive treatment for these problems is to get neurosurgery involved, and they can do a couple different things. One is to place a drain into the ventricular system and just drain the fluid right out. It's also a way that you can monitor exactly what the pressure is inside the brain. Ultimately, some people require actual removal of the skull, so that, especially if it's a process where the brain is kind of continuing to expand, such as with edema from a stroke, it allows the brain to expand rather than down the spinal canal, which is brain herniation, herniate out of the skull, which is it's alarming to look at, but less damaging.
And we have a couple of really cool videos of that coming up.
So intracranial hemorrhage is an important cause of structural coma to think about. We define different intracranial hemorrhages by where they occur within the cranium. So you've got intraparenchymal hemorrhages, which occur right within the brain tissue, and that's going to be your hemorrhagic stroke. And then there's extraparenchymal hemorrhages that occur between different meningeal layers, and they tend to have different causes and different presentations. One of the important distinctions between how a bleed ends up presenting is whether it's an arterial versus a venous bleed. Recall that the arterial system is a high pressure system, so if there's an arterial bleed, it happens fast, it compresses the underlying brain, and it has an acute presentation. A venous bleed, on the other hand, tends to be slower. It's a low pressure system, and so rather than compressing things, the brain kind of has some time to adapt, and it sort of gets displaced rather than compressed. And so this has can have a much more subacute or chronic presentation. So a review of those different kinds of hemorrhages.
Let me go back real quick. This is so great. This slide right here. I mean, if you understand this, you're doing really well in terms of understanding. So that's a great little figure to remember. Thank you for that.
So an epidural hemorrhage, if we go back to that
Sure.
slide, recall it, the dura is the outermost layer. So an epidural hemorrhage occurs between the dura and the skull. And because the reason that it occurs is that what is the usual cause of it is rupture of an artery that runs right underneath the skull.
Right here.
Yeah.
Right here. Usually the middle meningeal artery, right?
Yep. Which has the unfortunate fate of lying right below this thing called the pterion, which is just where a bunch of skull plates happen to meet, so it's a vulnerable part of the skull. So if someone gets hit in the skull right here, that meningeal artery, middle meningeal artery is likely to rupture, and because it's an arterial bleed, it quickly expands. It compresses the brain below it, causing this biconcave or lemon-shaped hemorrhage. And while it's rapidly expanding, before it reaches a certain threshold to cause decreased level of consciousness, there's this characteristic lucid period. So sometimes people will pass out initially as a result of concussion, come to, they seem totally fine. But you always have to be worried about the possibility that they're in a lucid period and that they've got an epidural hemorrhage that's quickly accumulating and can kill them if not intervened upon.
It's growing and growing and growing, and they don't recognize it.
Subdural hematomas, on the other hand, are kind of a different beast, in part because they are caused by venous bleeds. So there are these veins that run, they're called bridging veins, that run between the venous sinuses into the subarachnoid space. And if those tear, you can get a slow venous bleed. Sometimes, in cases of trauma, you can get a more dramatic subdural hematoma, but often with other types of bleeding involved. But sort of the classic scenario, and certainly for a board exam, is that an elderly person whose brain has been shrinking away from the skull and whose bridging veins have been have been stretched as the brain shrinks away, those veins tear with perhaps even very minimal head trauma, something that no one would have even thought to report, and blood slowly accumulates in the subdural space. And because it's accumulating so slowly, it doesn't really compress the underlying brain. It's not pushing it in. It's just following sort of the shape of the skull, forming this banana-shaped bleed.
Banana, that's a good one.
Banana, yeah.
So, and of course, we've seen at Hennepin a lot of alcoholics. Of course, alcoholics happen everywhere. Alcoholics get this for 3 reasons. One, their brain is shrinking, so there's more strain on those bridging veins. They fall.
Yep.
And they may have liver disease, so they don't clot particularly well. So that's a trifecta. So this is a very common hemorrhage in the setting of a chronic alcoholic.
Yes.
All right. Subarachnoid hemorrhages.
So subarachnoid hemorrhages is another emergency situation because it's an arterial bleed. This is most often caused by rupture of an aneurysm, and it causes very rapid filling of the subarachnoid space. So the subarachnoid space is between the arachnoid and the pia. And the pia hugs the brain surface, the actual gyri and sulci themselves. And because of that, when the blood fills the space in between, it's filling in all of the sulcal spaces that are usually there. So on a CT scan, rather than seeing dark space where the ventricles usually are, you see hyperdense blood in those spaces. The classic presentation of a subarachnoid hemorrhage is someone's walking along, they feel just fine, and all of a sudden they get a thunderclap headache, worst headache of their lives, really dramatic, sudden onset. Often there's nuchal rigidity because of the blood irritating the meninges, and there can be a relatively rapid decrease in consciousness because of the rapidity of this process. Trauma can also cause a subarachnoid hemorrhage, which generally carries a better prognosis than an aneurysmal rupture.
Okay, what do these look like on CT?
So, as we said, our subdural is our banana bleed because it's a venous bleed. It's happening slowly and gradually. It doesn't compress the underlying brain. An epidural bleed is your lemon bleed because it's a fast bleed and it's pushing the brain in as it's expanding. The subarachnoid, again, is blood filling up the sulci as it fills the space between the arachnoid and the pia that's hugging the brain. And then an intraparenchymal bleed is your hemorrhagic stroke, so just usually a big blob of blood somewhere inside the parenchyma itself. And this is just a summary of the differences between all of those.
Okay, so I got a few excellent videos here. So this is surgical evacuation of an epidural hematoma. And I'll just go ahead and play it here. So the skin has been pulled back, the scalp has been pulled back, and you're looking at the skull here, and they're about ready to go ahead and remove it. And what you're going to see is because this is an epidural, so here goes the skull, and there is the epidural hematoma.
It's right there under the skull.
And if you look closely, you can see it is pulsing. So they also need to tamponade off whatever, if it isn't already, the artery that was torn, that Dr. Starks mentioned. But look at the way it just almost kind of just can be just pulled out, and you'll see that the dura is still intact here. So that's important. The dura is still perfectly normal in there. And so it gets cleared up. They got to make sure they don't tear on the artery that originally caused the bleed in the first place. But already the patient is doing quite a bit better because their brain is no longer under pressure. There's the dura and the brain underneath it right there.
Yeah, and you can see how little space there is between the skull and the dura there, and that was a big amount of blood that they just removed.
Exactly. Okay, moving on, and there it's closed up, and they're going to close. So here is a subdural. So we're going to go in again. Here comes out the bone flap. you can see the dura here, but the blood is, they have to open up the dura in order to get the blood out. And when they open it up, you'll see these hemorrhages, notoriously, because they go so slowly, they tend to be of varying ages. And you'll see these loculations and these membranous loculations from the blood itself. So what you're looking at is the dura is coming back. That is the blood right there. And so they'll go ahead and either evacuate or go ahead and suction that out.
You can actually see that on a CT scan usually as well, that there's varying levels of brightness in the blood on a subdural because of the different sort of ages of the blood.
So there it is.
It also looks a lot less bright red, doesn't it?
Yeah. And so that's been, so they're taking the membranes off now. They'll go ahead and suction out the rest of the blood, close the dura back up, and they should be pretty good here. Anything that increases your risk of bleeding, anticoagulated state, will increase your risk for a subdural. And there it is. And you can see, now you can see the brain quite clearly. All right, now let's move on to what happens after a subarachnoid. This is, as Dr. Starks mentioned, you can get a subarachnoid hemorrhage after trauma or after a ruptured aneurysm. This is the aneurysm right here, and what they'll do is they'll do surgical clipping of it. And there's numerous studies that have been done on as to what size does an aneurysm need to get to before they clip it or coil it. And this is a dynamic process that is in development. As the techniques get less and less invasive, they go after smaller and smaller aneurysms. To state the obvious, if you've had an aneurysm that is torn before, they're more likely to be aggressive. So they just put that clip, and you can just see the aneurysm just deflate nicely. You have to be very careful not to clip off the vessel itself that it's coming off of, and there is a real art to this. So that's the clipping of the aneurysm. The other way to go about this is through coiling. So this is a interventional procedure. Here's the aneurysm right here, and here's the catheter going in, and they will end up putting all of these dozens of tiny little coils that fill up the aneurysm and then cause it to clot off. And then clear out, and then it allows the lumen itself to stay open. So there are all the tiny little coils that will then be clotted off.
So this one does not actually require brain surgery.
No, right? Yeah, this is an interventional radiology procedure.
Yeah. All right. So moving on to hydrocephalus, which literally means brain, water in the brain. This is when you have abnormal accumulation of the CSF. Your ventricles are getting bigger than they should, and that leads to compression of the brain.
Yep.
And it's one of the causes of increased intracranial pressure. There's two main types, two main ways to get this. Either you've got obstruction in somewhere along the channel of ventricles communicating with each other. So recall that we've got the lateral, third, and fourth ventricles, but they're all connected. And they cycle CSF through each other and back into the venous circulation. So it's really just simple plumbing. If you've got an obstruction of one of those channels, everything's going to back up proximal to that. So we can usually tell if it's an obstructive hydrocephalus because some of the ventricles, but not all of them, are enlarged. This is compared with a communicating hydrocephalus in which all the channels are open, but the arachnoid villi that usually are responsible for actually absorbing that CSF back into the venous circulation, those get scarred up. usually from a prior subarachnoid hemorrhage or meningitis.
Yep.
So there's scarring of those arachnoid villi. They're no longer able to absorb CSF through them and into the blood.
Mm-hmm.
So in that type of hydrocephalus, you get enlargement of all the ventricles. So as I said, depending on where the obstruction is, which channel it is between the ventricles, dictates which ventricles get enlarged. So
If you have a cerebral aqueduct stenosis, you'll get a blown third and lateral ventricles, but your fourth will be fine.
exactly.
Okay.
This is what it looks like on a CT scan. Ventriculomegaly is our fancy word for enlarged ventricles. And these are, of course, the lateral ventricles that we're looking at right here.
And I know we're going to get to this in a second, but when you're looking at this, Dr. Starks, what do you think of are you also looking at the sulci here?
Yes.
And what do you see here?
And the reason is, if this is true hydrocephalus and we're looking at increased intracranial pressure, that means that this increased volume in the ventricles is compressing everything around it. So the sulci that are normally space in between the gyri are getting squished. So we get sulcal effacement. Unlike hydrocephalus ex vacuo, which is actually not hydrocephalus at all, but rather the appearance of enlarged ventricles because everything, the brain around them is shrinking.
Yep.
So it's not that in true hydrocephalus, the ventricles are getting big and squishing everything around it. And in, for example, dementia, where the brain is shrinking, the brain shrinks away and causes all the spaces to get larger, including the ventricles as well as the sulci in between gyri.
Got it. I put this slide in here. This is just an example of hydrocephalus management. So this is an example of either communicating hydrocephalus or obstructive hydrocephalus at the level of the cerebral aqueduct, because this is an enlarged third and enlarged lateral ventricles. This is causing damage and compression of all of these cortical structures. This is the same patient. Look what happens after you put a drain in or a shunt that Dr. Starks was talking about earlier. You get a drain into those ventricles, drain it off, and all of a sudden the brain returns to its original structure and avoiding the damage to the cerebrum.
So when increased intracranial pressure gets bad enough and there's nowhere else for the brain to expand unless someone has taken off part of the skull and it can get out that way, the only place really for it to go ultimately is down the spinal canal, which is bad news bears, because this is where not only our reticular activating system lives, but a lot of other important stuff that keeps us alive in the brainstem.
Worthwhile to comment on kids before the fontanelles, before the sutures fuse.
Mm-hmm.
So one of the advantages of not yet having a fused skull is that if kids can swell and not have damage because their brain is able to open up a little bit. This is where you'll see the split sutures.
They don't have that fixed volume that we're stuck with.
Yep.
So the most common type of herniation that we see and that we look for is the uncal herniation, which is the type of herniation that really kills you because it's herniation of the uncus, which is in the mesial temporal part of the brain, into the brainstem and sort of downward.
Yep.
The way to identify this clinically is your classic blown pupil. The reason that occurs is the cranial nerve 3, which exits from the brainstem right next to the uncus, is the first thing that gets compressed in an uncal herniation. Cranial nerve 3 itself, as you remember, controls both eye movements as well as parasympathetics to the eyes, so it's important for pupil constriction.
Yep.
And those parasympathetic fibers run on the outside of the nerve. The motor fibers are on the inside. So the first thing that happens when something pushes against the nerve is the parasympathetics go out.
So even before you lose the eye movement, you get the blown pupil.
It's no longer able to constrict. It gets really, really big. The cranial nerve 3 exits the brainstem in between the posterior cerebral artery and the superior cerebellar artery. Because of this, as after cranial nerve 3 gets compressed, the next thing to go is posterior cerebral artery. So that leads to essentially a PCA stroke, resulting in a contralateral hemianopsia that honestly, clinically, we usually don't pick up because a person is quite unconscious at this point. So the blown pupil is usually the key to seeing this syndrome.
Yep.
As things progress even further, the brain is pushing and pushing and pushing. Ultimately, the brain stem gets compressed against the other side of the brain, so-called Kernahan's notch. And this results in compression of the other cranial nerve 3, as well as the cerebral peduncle on that side. So at this point now you've got both blown pupils and weakness on the side contralateral to the cerebral peduncle.
Which means, getting confusing as we go along here, which means actually your body weakness, your upper motor neuron weakness to the extremities is actually on the ipsilateral side of the lesion.
Right. So if we use the example of a hematoma on the right side of the brain, you first get uncal herniation on the ipsilateral side, the side of the lesion, resulting in a contralateral blown pupil.
Ipsilateral blown pupil.
Thank you, ipsilateral blown pupil.
That's okay. See, this is important. Even staff neurologists get this confused a little bit.
So an ipsilateral blown pupil
Yep.
and a contralateral field cut from the ipsilateral PCA. And as things progress further, you get both blown pupils as well as the the contralateral cerebral peduncle, which controls the contralateral side of the body.
Yep.
Contralateral plus contralateral equals ipsilateral weakness.
This is an excellent example of the fact that there's nothing wrong with actually stopping for 10 seconds and thinking.
Exactly. There's a lot of...
We still do it all the time.
Yes.
Did anything else you wanted to bring out about uncal herniation? So that's great. Just a couple pictures here. So I think one of your roles as physicians, in whatever capacity you are, primary care doc, emergency room doc, maybe you're a dermatologist and you are now the family member who is helping or manage your beloved cousin who's going through something like this. One piece of information we want to share with you is it is our job as physicians to help people get over the idea that they need to keep their skull on. Right? I mean, this is a situation where you don't hem and haw, you take the skull off. This was learned in the wars of Iraq and Afghanistan, where really the acute treatment of closed head injury changed quite a bit because they were doing in the field after closed head injuries. They were doing before even CT scans. They were just taking skulls off. And the reason, and this was then very quickly adapted by trauma surgeons here in the States, and for the very good reason is that the outcomes were better. You were able to allow the brain to swell out. You didn't have the infarction from the increased intracranial pressure that we went over.
But you have to do it before the damage is done.
Right. So don't screw around. Take the skull off. All right. And so here's just an example. So here is a subdural hematoma on MRI scan, and you see the acute compression, which is, even though subdurals can sometimes be acute, they're usually subacute or chronic. But you see the herniation syndrome here. Take a look what happens when you take the skull off. So here goes the skull, and look at the brain parenchyma just swell out. It is so happy. And this is a few days later after it's calmed down. You have saved all of this brain tissue from infarction and possible death.
So, although we're always on the lookout for structural causes of coma that might warrant neurosurgery or other interventions, really probably the most common cause of a coma is actually anoxic brain injury or hypoxic ischemic injury, which is usually caused by a cardiac arrest, sometimes a respiratory arrest. And one of the important things that informs how this looks clinically is the fact that our cortical neurons are really selectively vulnerable to lack of oxygen. And when there is global reduced perfusion to the brain, as in a cardiac arrest, the first things to die are the cortex and the hippocampi.
Yep.
The brainstem itself is pretty resilient. And for this reason, cardiac arrest rarely causes true brain death, as we define it both medically and legally. Because brain death is defined as loss of brainstem function.
And if you think about it, the very last region of your body that should get the last burst of oxygenated blood is your medulla, right?
Yeah.
Absolutely everything else goes. And it's rare. I think we would point out that it's rare that we in the hospital actually see full, complete brain death. It's far more often we see minimally conscious state or persistent vegetative states, because usually if they get to the hospital, that means somebody resuscitated them,
Right.
and they were able to resuscitate enough of that medulla to keep the breathing going.
Which leaves us often in somewhat of a limbo, because while different people define a meaningful life differently, many people consider the cortex to be the part of our brain that really makes us who we are, the thinking, feeling, emotional beings that we are.
Memories.
And so we're often in a situation where we have to explain to family that although the parts of the brain that help us breathe and help our hearts beat is still alive, and a person is still technically alive, the part of the brain that makes them human and who they are is gone.
And just a comment here on how we work through this is that our job is to help the family, friends, communicate what their wishes are. Because if whoever it is, it doesn't matter what Dr. Starks or I think, and it also doesn't matter what the family thinks. I'm sorry, let me take that back. It doesn't matter what the family wishes.
Right.
It matters what the patient themselves would have wished, of which it is the family's job to help communicate whatever that is.
Right.
All right. And what's
easier said than done.
And it's easier said than done, but it also takes the pressure off them. It's just like, I don't need to decide whether or not my mom's going to stay on a ventilator or not. I'm going to communicate what my mom would have wanted.
What would have she said if she were sitting in this chair right now?
Right, which is a lot easier than me taking it on and answering for her. Okay. Oh, we gotta click over. There we go. Sorry. Okay.
So in evaluating a coma, besides looking for asymmetry, we're also trying to determine, I guess one thing that's not on this slide is we're trying to determine the level of consciousness. So a person can be in a coma but still react somewhat to someone's voice, or might withdraw meaningfully when I pinch their fingers, or they might have no response at all. And those are clinically meaningful because they give us some indication as to how much the cortex is still there.
Yeah.
Is there any sort of subconscious awareness? But we're also able to actually test a lot of cranial nerves in a coma exam. We can test a blink reflex by dropping saline into someone's eyes, and that gives us information about whether the trigeminal nerve, which is the input to that reflex, and the facial nerve, which is the output to blink, whether those parts of the brainstem are intact. Similarly, the pupillary reflexes give us information about cranial nerves 2 and 3. And also about the sympathetic nerve fibers, which primarily run in the pons. So if there is a structural cause of coma just right in the pons, wiping out the sympathetic fibers, the pupils are no longer able to dilate, and the parasympathetics are unopposed, and you get these pinpoint pupils, which are characteristic of a pontine lesion. Conversely, as we talked about with herniation, if the midbrain is being compressed and the cranial nerve 3 parasympathetics are being knocked out, you instead get blown pupils on both sides.
Got it. And so it's optic nerve 2 in and optic nerve 3 out for constriction. and it's optic nerve for dilatation. It's optic nerve 2N, but then it does that crazy sympathetic down the cervical ganglion and up to eventually the dilator of the pupil.
Yep.
How did I do? All right, good.
So locked-in syndrome is really not technically a comatose state, but it mimics a coma.
Yeah.
So this is a really unfortunate condition in which the ventral part of the pons get knocked out. And within the ventral pons, you have the motor pathways that are coming down from the brain to the rest of the body, as well as the cranial nerve 7 and some of the lower cranial nerve nuclei that are important for facial movements and speaking. And so these individuals are not able to move and they're not able to speak, but the reticular activating system itself is still intact, and so is their consciousness. So they're locked in. By happenstance, the vertical gaze center is above the pons. It's in the midbrain area, and so as is the cranial nerve 3, as you know. And so those parts randomly get spared, and so these individuals can move nothing except for their eyes vertically and blinking.
And so, do you have any locked-in stories that you can think of? I still remember the first one I saw at Hennepin of a guy who had a horrible uncontrolled diabetes, who's about my age now, and we got the story of he's unresponsive, and you just walk in the room and it's just like he's right there, right?
Yeah.
I mean, it's just like you get used to seeing, comatose people in eyes that are just, disconjugate. And,
There just isn't that.
he's just right there, and I'll never forget that one. But it was wide awake, and he had vertical eye movements.
Wow.
And we had we put a sign up at the patient conscious, fully aware of everything that's going on. Any similar stories you can think of or anecdotes?
I haven't had one.
Not yet.
Quite like that, no.
Okay. But so.
Was it a stroke then, or?
It was a stroke. Yeah, it was a big basilar infarct.
Which is what happened to the person who wrote this book that was later turned into a movie called The Diving Bell and the Butterfly. A French editor of a magazine suffered a basilar stroke and got this syndrome, and amazingly penned a memoir about it entirely through blinking the alphabet with a speech therapist. Another cause of this terrible syndrome is central pontine myelinosis, which is pictured right there, in which there's demyelination of the fibers that run through the pons, and in particular the ventral pons, where the gray and white matter, where all those motor tracts interdigitate.
Right here.
And are particularly susceptible to edema. The cause of this is most often rapid correction of hyponatremia. So when someone becomes hyponatremic and they get swelling of their neurons, eventually the brain, compensates osmotically and everything kind of levels out. If one aggressively corrects the sodium with a hypertonic saline like this, all that osmotic compensation reverses and the water comes rushing out of the brain cells, they shrink up and die and demyelinate. So don't do that.
Right. Well, so this is why when and people you'll see in the hospital. So what's the normal range for sodium? 135 to 145, something like that. So we will see. You really get worried about this if it gets less than 120. I haven't seen it much less than 110 before. But once it gets pretty low, you have to be very careful not to overcorrect. And the standard rule that I'm aware of is that you don't want to correct more than, say, 10 milliequivalents per liter of sodium per 24 hours. So if on Monday morning at 6 they have a sodium of 110, by Tuesday morning at 6 you don't want to have it more than 120. and Wednesday 1:30, and so on.
And I should mention a common question that comes up when we're talking about hypertonic saline for the management of increased intracranial pressure, like we did earlier.
Yep.
Is that people are often nervous about giving too much hypertonic saline for fear of causing this condition.
Okay.
This really only occurs if you first have this state.
If you got to be first hyponatremic.
You have to be hyponatremic, and typically for a while.
Okay.
So hyponatremia typically has to be present long enough that there's been time for this osmotic compensation. If someone is in a normonatremic state, hypertonic saline is really quite safe.
Okay, that's good to know. All right. So one of the most common things we get called about is altered mental status.
Which is, as one of my old attendings used to say, delirium is not a neurologic condition, meaning
okay,
that...
who was that?
It was actually Will Schmalstig over there.
Oh, Dr. Schmalstig.
Yep, he would write this in big red letters on our whiteboard every time he was on service.
I love it. So Dr. Schmalstig is a very astute, excellent demyelinating disease specialist, but anyways, also a very little pearl there. Okay, go ahead.
And what he means by that is that we often get the question of, this person is altered, could this be due to a stroke or a primary neurologic problem? And the answer almost always is no. And just like in a coma, when I go to see a patient like this, what I'm asking myself is there something focal or lateralizing that would point to there being a neurologic problem?
Right.
If not, if everything looks diffuse and symmetric, it's almost always due to what I kind of consider bad humors in the blood. So something is off in the blood that systemically that is making the brain not function well.
Which could be any of these options. We don't need to roll through each of them individually, but this is the reason why we have, our medical panels and
basically
electrolyte panels.
Metabolic problems, infectious problems, and quite commonly, what have we been giving these people?
Yep.
Delirium or encephalopathy really is a problem of attention.
Yep.
So we talked about wakefulness, alertness, and awareness being important for consciousness. The next most high level, or the next level function is attention. So you're not just aware of your environment, you're able to appropriately pay attention to salient stimuli and appropriately respond to them.
These are the people, if you stimulate them, you give them a little painful stimuli, they'll look at you and then they'll drop off as soon as you
and then 2 seconds later they're looking at something else.
A term commonly used for that is obtundation.
So delirium is characterized by this impaired attention. They're really distractible. They're looking all over the place, or at least not able to attend to something for a long period of time. They tend to fluctuate, so that you go and see the patient in the morning and you tell your attending that they're completely unarousable, they're sleepy, and your attending goes to see them and it's a completely different picture because it's 2 hours later and now they're up and agitated
and they're awake.
Wide awake. So fluctuations are key. These people are subject to sensory misperceptions and also frank visual hallucinations that can be quite complex.
Yep.
The sleep-wake cycle breaks down. People are up at night, sleeping through the day, and because of all this confusion, they can act out, perceiving threats that aren't real, things of that nature. My favorite exam finding is a key to determining if this is an encephalopathic process, the so-called hand-flapping tremor, which you have to check for it to know if it's there, but when I see this, it's confirmation to me that this is not a primary brain problem, it's bad humors.
It's just it's the brain's ability to maintain tone is just not quite complete.
It's just these sudden, rapid losses of muscle tone.
Let me give it, and that is exactly what it looks like. So this is a subtle example, but you tell them just to hold up your hands like you're stopping traffic.
You have to have them do it first. Hysterexis.
Yep. All right.
So check that in everyone you see in the hospital. So So, a lot of different causes of altered mental status. We talked about most of them being sort of toxic, metabolic,
Yep.
infectious problems. Alcohol withdrawal is a common cause of encephalopathy. Essentially, if you are chronically exposed to alcohol, which is a depressant,
Mm-hmm.
your brain gets used to it and compensates by decreasing its sensitivity to GABA, the inhibitory tone, and upregulating excitatory tone. So the balance gets shifted, and
Mhm.
if you all of a sudden then remove the alcohol, that CNS depressant, everything reverses. So your system gets revved up.
And just glutamate is the excitatory neurotransmitter. GABA is an inhibitory neurotransmitter. So alcohol, which is just, if you think about it, it's just this tiny little molecule. Is just two carbons and an OH group on it, and it's a depressant, and so it can throw the balance between GABA and glutamate off.
And once you're in this hyperexcitable state, your autonomics are upregulated, you're tachycardic, your blood pressure's high, you might be hyperthermic.
Yep.
Tremulousness or the shakes are very common early on as a sort of a sign of motor hyperexcitability,
Yeah.
cortical hyperexcitability, and in a more severe state, you can actually have seizures. And so this is the rare drug withdrawal that can actually kill you.
Mm-hmm.
Seizures usually occur 12 to 48 hours after the last drink.
Yep.
But it's really important to be aware that alcoholics are also at increased risk of true epilepsy. So someone who comes in time and time again with alcohol withdrawal seizures, you have to still wonder whether they might have a focal
Mm-hmm.
lesion in their brain from perhaps one of the many falls they've had.
Yep.
That warrants them being on anticonvulsant therapy.
And as Dr. Asadi goes over in the seizures brain pod a little later, in order to have epilepsy, your seizures need to at least be occasionally non-precipitated. So it can't just be alcohol withdrawal seizures. You don't end up epileptic. But if you are an alcoholic, you are in increased risk of having not only alcohol withdrawal seizures, but ultimately epilepsy seizures.
Which is why someone coming in with an alcohol withdrawal seizure, especially if they've had multiple, they are still deserving of a seizure workup.
Yep.
To see if they've got
Especially first time.
a big lesion. Yep.
Yep, first time. You want to talk about the pink elephants? There?
So Pink Elephants, this is Dumbo's an amazing movie. If you go back and watch it, it really is. So Dumbo, if you recall, he got drunk and started seeing pink elephants.
Is that true?
Yeah.
I gotta watch.
No, seriously, go
Dumbo.
back and watch
I
it.
will
It's
go
really,
back and watch it.
Super trippy. It's kind of amazing.
What was up with Walt Disney? That's hilarious.
Yeah. And there's this famous beer from Belgium called Delirium Tremens.
Yes, right
with
here.
the pink elephant.
Right.
Although in fact, pink elephants are usually what you see with alcoholic hallucinosis, where you see hallucinations, but you're not agitated and things like that. Delirium Tremens, you are typically not hallucinating pleasant pink elephants, rather disturbing things like bugs or things like that.
And DTs is a neurological emergency. I mean, it is without treatment, the mortality is very, very high.
Yeah.
And so
And that one occurs later on as well.
True.
So
Yeah.
you can be out of the window of alcohol withdrawal, but still at risk of developing DTs.
3 days later. Is that how far? How long would you
I
go?
think it's up to a week.
A week later. Okay, so that's
I
a
think-
long time.
I believe alcoholic hallucinosis is kind of the in-between.
So you're managing this hyper excitable state, which I put down as hyperadrenergic, but it's not just norepinephrine; it's also glutamate, and you calm that down through benzodiazepines, diazepam, lorazepam drip, and all of the scales of dosing goes out the window with these. You just you give them sometimes up to massive doses to keep the heart rate down, keep blood pressure under control. And then cardiac monitoring, watching for arrhythmias.
Wernicke-Korsakoff syndrome is really two different syndromes. There's Wernicke's encephalopathy, which is clinically defined by the classic triad of encephalopathy or confusion, plus an ataxic gait, and a variety of different ocular findings. So impaired eye movement or nystagmus, especially if it's vertical. And this is caused by thiamine deficiency. And it's not just, I think classically we think of it in alcoholics. Not only are they prone to not getting enough thiamine in their diet, but alcohol seems to actually inhibit absorption of thiamine.
Oh, okay.
But any kind of really low nutrition state can cause this. In fact, I had a memorable case as a medical student at Hennepin County. I guess all of our stories are from the county. We had a patient who was homeless and also a vegan, which turns out is not a good combination. He was not getting a proper vegan diet at his homeless shelter, so he just stopped eating altogether.
Wow.
And he developed Wernicke's encephalopathy. So that was a useful reminder that you should think about this not just in alcohol.
Yeah, and this is one of those weird syndromes that really does happen frequently. There's a reason why this is on every step examination, because it really does happen. You can miss it very easily, and it's reversible.
And sometimes it goes on. If you do miss it, individuals can go on to develop Korsakov's syndrome,
Dementia,
in which they cannot form new memories and also have a little bit of frontal lobe disinhibition, so they can fabulate.
I love Korsakov's psychosis as explaining a lot about the human nervous system. We are a social creature, and so I challenge anybody, if I were to suddenly wipe out the last 3 hours of your life, you would make up whatever you need to make up so that you're getting along with what, because we're social, right? We don't, and so I mean, like, if I were to blank out the last 3 hours for you, you'd be like, first of all, why am I standing here, sitting
here? You're like, well, I'm in an office, so I assume we're having an interview right now, and yes, we probably have, you're right, we have met, that's right. You were,
Right, but people, you can ask them things you know about. So if they're in the hospital, what did you have for breakfast today? Oh, it was great. I went to the Ramada for their brunch, which is fantastic.
Or have we met before?
Right, okay. That's a great one.
Or what are you up to today? I had a patient say, well, I'm going down to the mall. I'm going to pick up some nylons. Do you want me to get you some?
They're in the ICU. Right?
Yeah.
Yeah. So but it tells you a lot that there is just an incredible drive to just kind of fit into whatever situation that you're in, and if you're not laying down memories, you'll fake it. How do you treat this? You just have the low threshold for treatment. Give a high dose. I don't think you even need to know what the dose is exactly.
Just give it parenterally as well. Give it IV because to make sure that it gets absorbed.
Now, you want to avoid giving glucose, and the reason for this is that in the Krebs cycle, in numerous different glycolysis pathways. Yeah, I know. I had to look this up after our last break pause. Is that thiamine is a cofactor. TTP, thiamine pyrophosphate, is a cofactor in like 5 of those different enzyme pathways. So if you give too much glucose, you just put a lot of substrate in, you exacerbate the already thiamine deficiency. So just a couple things. We're just going to go over serotonin syndrome and neuroleptic malignant syndrome, and then we'll call it a day.
So serotonin syndrome has gotten a lot of press, in part because the serotonin syndrome led to actually the work hour restrictions that we now have for medical residents.
Yep.
So there was a very high profile case in which the daughter of some very wealthy, powerful man.
He was he was a columnist for the New York Times.
Okay. Yeah. She died while she was in the hospital, and her death was blamed on overworked, sleep-deprived residents who had given her too many serotonergic medications. As it turns out, this probably was an oversimplification of the situation.
Right.
However, it led her dad to kind of go on a mission to correct the problem of residents working nonstop.
Right, and not only, and it says medical students getting gift to sleep, but it's actually really residents.
Mm-hmm. Medical students, you actually don't have work hour restrictions. Sorry.
Sorry. Surprise. All right. So let's talk about what happens with serotonin syndrome.
So serotonin syndrome is, as you may imagine, it's just too many serotonergic agents on board. There are a lot of them out there, some that you might not even think about. So it's important to be able to recognize the clinical features of this.
So antidepressants, triptans for migraine headaches,
And things like
monoamine.
Zofran,
Yeah, I wouldn't necessarily think of Zofran, but yep, in there as
certain
well.
antibiotics.
And combination, anything that can screw with the metabolism of these agents
Right,
too, right?
right.
So, okay.
So when to think about serotonin syndrome, so it can come on pretty acutely. This is something that causes confusion. And everything here kind of gets revved up. So there's neuromuscular excitation, which manifests as hyperreflexia that for some reason seems to affect the lower extremities more so than the uppers. There's increased tone. You can have myoclonus, so everything is really excited. Also, autonomically, everything is revved up, high heart rates. You can have a fever, diaphoretic, and also because serotonin has a role in basically regulating our bowels, you get
Yep.
a revved up bowel system.
Yep.
So bowel sounds might be increased, and people might have diarrhea.
I think is there more serotonin receptors in our gut than in their brain?
Probably.
I don't know.
It's a big nervous system.
It's a big nervous system.
A syndrome that can look a lot like serotonin syndrome is neuroleptic malignant syndrome, which is also something that can kill you, so important to recognize. And this is caused by medications that are antagonists of dopamine. So most commonly antipsychotics, especially the older first generation ones, as well as certain antiemetics like Reglan and Compazine. So this has similar features in terms of tachycardia, fever, confusion, but rather than having neuromuscular excitation, you actually get more of a Parkinsonian syndrome, which makes sense when you remember
Yep.
that Parkinson's is caused by a deficiency of dopamine. So you get muscle rigidity, lead pipe rigidity like you see in Parkinson's and bradykinesia, and reflexes, importantly, are reduced in contrast with serotonin syndrome.
I love this figure. This is awesome.
Thank you, Google.
But in addition to that, you get the same you get some of the similar autonomic derangements. So you get called patient confused. They're autonomic. They're tachycardic. They're diaphoretic, and often they are on all of these agents. They're on a bunch of neuroleptics.
Yeah.
They're on a bunch of antidepressants. Which is it? I think probably the rigidity is more helpful than just about anything.
And also, fortunately, you all carry your reflex hammers at all times, so you'll be able to sort this out.
It's just a nice summary slide that kind of teases, that helps pick up the main pearls in terms of differentiating these two syndromes. Management. So obviously for both of these conditions you remove the offending agent. If it's serotonin syndrome, you address the hyperadrenergic, or maybe we should call hyper excitatory state with benzos, as well as you can use propranolol as a beta blocker. And then because you have too much serotonin, you can directly antagonize the serotonin receptors with either cyproheptadine or methysergide. Conversely, with neuroleptic malignant syndrome, in addition to removing the offending agents, because of the rigidity, you want to watch for rhabdomyolysis, and because of that, you use IV fluids. You can again address the hyperexcitatory state, but because the problem here is too much blockade of dopamine receptors, you want to enhance dopamine activity, and you can do that by giving bromocriptine, a dopamine agonist. And anything else on? I think that's enough, right? I think
I think I'm ready to go.
It would say, well, hey, look,
Oh,
it's
hey.
sleep right next. We should
Perfect.
could take a little
Timing.
nap. Next on Brain Pods, we're going to have Dr. Con Iber and myself, and we're going to do a sleep review. Dr. Starks, thank you so much for this excellent summary of Coma and consciousness. You will see Dr. Starks again when we go over cognition and we go over movement disorders. I don't know if Brianna Tarth is going to be there, if it's going to be someone else next time.
Maybe a Stark.